Good evening, everyone. How are you? Hope you are doing good. Today, I want to discuss about one of the important anti-diabetic agent, that is SGLT2 inhibitors. Let's go into the topic. So, what is SGLT2? It is a sodium glucose cotransporter. Where it is located? Almost exclusively in the proximal portion of the renal tubule. So, it is a high affinity, low capacity transporter. So, what is the function of SGLT2? It moves the glucose against the concentration gradient from the tubular lumen. How it is doing it? By using the energy generated from the sodium flux to the epithelial cells. So normally it is causing reabsorption of the glucose. So renal retention of the glucose is nearly complete in non-diabetic persons. And SGLT2 alone accounts for about 80 to 90% of this reclamation. So remaining 10% of the glucose will be recovered by SGLT1, where it is present distally in the proximal tubule. So early studies in diabetic animals, they demonstrated that the hyperglycemia could be nearly ameliorated by the naturally occurring compound called fluorescein. This fluorescein is an SGLT inhibitor. So based on this proof of the principle, the drugs that are specific inhibitors of SGLT2 have been developed to treat the diabetes. So these agents, they block the glucose transport in the proximal tubule. So it blocks the reabsorption of the glucose. So what will happen? Glucose will be excreted in the urine. So what will it lead to? It will lead to lowering of the blood glucose by promoting urinary loss of glucose, that is glucosuria. What is the mechanism of action and pharmacological effects of SGLT2 inhibitors? SGLT2 inhibitors, they reduce the rate of glucose reclamation in the proximal tubule. So it shifts the renal threshold for glucose excretion from about 180 to 50 mg per deciliter. So it reduces the renal threshold so that the glucose will be excreted in the urine, that is glucosuria. So in monotherapy, SGLT2 inhibitors reduce A1C level by 0.7 to 1%. It causes weight loss of around 2 to 4 kgs and decreases the blood pressure by 2 to 4 mm of mercury. So there are currently 4 SGLT2 inhibitors available for clinical use. What are they? Canagliflozin, dapagliflozin, empagliflozin and ertugliflozin, while several other members of this class still in development. So these agents are indicated for use in combination also with other oral agents and insulin. Such combination use leads to an additional decrease of A1C of 0.5 to 0.7%. Nowadays, SGLT2 inhibitors are also available in combination with metformin, also in combination with DPP4 inhibitors. A combined SGLT1 or SGLT2 inhibitor is also under investigation. Available SGLT2 inhibitors, they share favorable pharmacokinetic properties. They have very good oral viability of 60 to 80%, that is not affected by the food. So it reaches the peak level around 1 to 2 hours after the ingestion of the drug. They are about 90% bound to the circulating proteins with half-life of around 12 hours, which makes them suitable for once daily dosing. These compounds are metabolized by glucuronidation and the inactive metabolites renally excreted. There is virtually no renal excretion of the parent drugs. So all three drugs are available in the 2 doses. Dapagliflozin is available as 5 and 10 mg. Canagliflozin is available as 100 and 300 mg, and empagliflozin is available as 10 and 25 mg. So what are the adverse effects and drug interactions of SGLT2 inhibitors? The side effects of SGLT2 inhibitors are predictable from their own mechanism of action. There is a small 1 to 2% increase in the lower urinary tract infections and 3 to 5% increase in genital mycotic infections also possible. Urinary glucose losses causes mild diuresis. This diuresis can lead to hypotension and associated symptoms in a small percentage of usually older patients it can cause. Importantly, the SGLT2 inhibitors ultimately depend upon the rate of glucose filtration to be effective. And potency of the SGLT2 inhibitors decreases by 40 to 80% across the spectrum of stage 3 kidney disease. When the GFR is 60 to 30 ml per minute, its potency decreases by 40 to 80%. So SGLT2 inhibitors, they do not cause hypoglycemia, but can increase the likelihood when it's combined with other drugs that is causing hypoglycemia. The recent analysis of clinical trials with SGLT2 inhibitors suggests that they may increase the risk of fractures. This is an FDA warning. And there is preliminary evidence that these drugs also affect the mineral balance and circulating levels of parathyroid hormone and 1,25 hydroxy vitamin D, which is an activated form of vitamin D. The studies are also going to see if this is a significant problem with SGLT2 inhibitors. There have been rare cases of diabetic ketoacidosis reported in patients treated with SGLT2 inhibitors also. So in phase 3 clinical trials, there was no evidence that SGLT2 inhibitors had adverse effects on cardiovascular disease. So in contrary, the data from controlled trials indicate that empagliflozin and canagliflozin reduce the risk for major cardiovascular events. Unfortunately, canagliflozin is also associated with an increased risk of lower extremity amputations. A lot of fractures has been reported with this drug. The fourth drug approved is ertugliflozin. It's a drug for the treatment of type 2 diabetes mellitus. In the United States, it was approved by FDA for use as a monotherapy and as fixed drug dose combination with either with DPP-4 inhibitor, sitagliptin, or with bigonide metformin. So talking about ertugliflozin, the mechanism of action is SGLT2 inhibition. That you know, it lowers the renal glucose threshold. So it will by lowering the renal glucose threshold, it results in increased urinary glucose excretion, indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes patients. Dosing is recommended. Starting dose is 5 milligram we can give in the morning. If the dose are tolerated and if the additional glycemic control is needed, we can increase the dose up to maximum 15 milligram per day. 5 to 15 milligram we can increase if there is an additional glycemic control is needed. So adverse effects, the same like other drugs, can cause mycotic infections, UTI, can cause hypotension, volume depletion, adverse effects like hypotension, headache, vaginal pruritus can cause. So what are the other indications of SGLT2 inhibitors other than diabetes? So this is a very breakthrough. The FDA recently approved dapagliflozin and empagliflozin for the treatment for heart failure. Thank you so much for your kind attention and kindly share my lectures to your friends.